Hi doctors, this NEETPG 2022, I think very easy question from pharmacology. I hope that all of you done very well. In this video, we are going to discuss the recall questions of pharmacology NEETPG 2022. To start, which of the following is the growth hormone receptor antagonist? Options are pegbisomin, mecasermin, bromocriptine, octreotide. The question, growth hormone receptor antagonist. So straight question, the answer is pegbisomin. Whereas mecasermin is a insulin-like growth factor analog useful for treatment of dwarfism. Bromocriptine, a D2 agonist useful for treatment of acromegaly. Octreotide, a somatostatin analog useful for treatment of acromegaly. So this question based on acromegaly. This question we discussed in the regular class as well as in TNT paper. For treating acromegaly, we have one thing called growth hormone receptor blocker. Growth hormone acting on a receptor. The receptor for growth hormone is enzyme linked receptor. The enzyme name is Janus kinase and JAK. So the action of growth hormone at the receptor level can be blocked by one drug that's called pegbisomin. This was the question asked in your NEET paper. Okay. Whereas the other option for treating acromegaly, we have one more group of drug that are going to inhibit the growth hormone release from pituitary. That can be done by somatostatin analog like octreotide, lanreotide, vepriotide, seglitide. And we have one more group of drug called D2 agonist called bromocriptine cabergoline. In this one special point, most of drug useful for growth hormone acromegaly is injectable, whereas D2 analogs of orally given drug useful for treatment of acromegaly. In this one more extra point, we have one drug called periotide, a somatostatin analog useful for treatment of acromegaly. The same drug also useful for treatment of Cushing syndrome. Of course, one more option for treating dwarfism, we have one IGF, insulin-like growth factor analog called mecasermin. It is a IGF analog combined with the IgO binding protein 3. The IgO binding protein 3 is added to maintain the stability of the drug. It's an injectable drug. Since it's an insulin-like factor, it may cause adverse effect of hypoglycemia. All these things are we regularly discussed in our classroom. So straight question, easy question. The second question, a female with ovarian cancer was on cisplatin therapy. She presented to hospital with several episodes vomiting. After giving an anti-emetic drug, the patient developed dystonia. The anti-emetic drug most likely to be responsible for this feature is what? Very straight question. Patient was given an anti-emetic drug. Following this, developed adverse effect of acute muscular dystonia. That means is one type of extra-pivotal symptom. A anti-emetic causing EPS may be D2 blocker. So in this way, look at the option. The options are metoclopramide, domperidone, ondansetron, promethazine. Here, metoclopramide, domperidone both are D2 blocker, but in this, metoclopramide able to crosses the blood-brain barrier. So this is one causing side effect of acute muscle dystonia EPS. So the answer will be option A, metoclopramide. Whereas domperidone, even though a D2 blocker, this will not cross. It will not cross blood-brain barrier, so no risk of EPS. So that's a point. Whereas ondansetron is a 5-HT3 antagonist that is not going to cause any problem of EPS. Promethazine is a first generation antihistamine. Here one interesting point. Most of the first generation antihistamine has Additionally, anticholinergic property also. Because of this action, in fact, promethazine can be useful for treatment of dystonia, for treating dystonia. So, this question, for example, metoclopramide, a D2 blocking anti-emetic agent, this may cause adverse effect of acute muscular dystonia is one type of EPS. For treating the drug-induced EPS, we go for centrally acting anticholinergic. Centrally acting anticholinergic. For example, either we can go for promethazine or benzoxazole. Benzoxazole also called trihexyphenidyl. Trihexyphenidyl, one of the commonly used centrally acting anticholinergic. Okay, here what we discussed in classroom, the same picture I discussed. Okay, and metoclopramide, dumbbell, both are D2 blocker. This also we discussed in our classroom discussion. Here, metoclopramide having D2 blocking property as well as some extra property of 5HT3 antagonism and 5 agonism. Because dumbbell purely a D2 blocker. Among the two drugs, metoclopramide able to cross the barrier, whereas dumbbell does not cross the barrier. Thus why metoclopramide causing adverse effect EPS, whereas dumbbell do not cause EPS. But both the drug causing common adverse effect galactorrhea, because galactorrhea is due to excessive prolactin secretion. See, D2, dopamine normally controlling prolactin secretion. Dopamine normally inhibits prolactin secretion from pituitary, whereas dopamine blocker will increase prolactin release causing galactorrhea. In fact, pituitary not covered by blood-brain barrier, not covered by blood barrier. So, metoclopramide, dumbbell both can act on pituitary and causes increase in prolactin release. So, both can cause galactorrhea, but metoclopramide alone will cause EPS. Dumbbell do not cause EPS. Next question. A pregnant female with urinary infection took antimicrobial drug for the same. The baby of this female developed a tendon rupture and arthropathy. What is the likely mechanism of action of antimicrobial consumed by the pregnant female? Very interesting question. In less than 6-year-old child and in more than 6-year-old patient, a drug going to cause tendinitis or tendon rupture mean it is mostly fluoroquinolones. They are the one causing adverse effect at tendinitis or tendon rupture. So with this in mind, look, we know fluoroquinolone mechanism action inhibiting DNA agarase. So with this in mind, look at the option. The options are folic acid synthesis blocker, mycolic acid synthesis inhibitor, DNA agarase blocker, protein. So my given drug is fluoroquinolone. Fluoroquinolone mechanism action will be inhibiting DNA agarase. So answer is option number C. Whereas folate synthesis blockers are sulfonamide. It's not a sulfonamide. Sulfonamide do not cause tendon rupture. Mycolic acid synthesis blocker. Most of the anti-TB drug, for example, isoniazid, and then we have pyrazinamide. They're all acting by inhibiting mycolic acid and they don't cause tendon rupture. Protein synthesis blocker, a lot of drugs are there like aminoglycoside, tetracycline, and they don't cause arthropathy in newborn baby. So tendon rupture or tendinitis adverse effect of quinolone and quinolone mechanism action will be the two mechanism action. They are acting by inhibiting DNA agarase in case of gram-negative infection and also having action of inhibiting topoisomerase 4 enzyme in case of gram-positive infection. So for this question, the right answer is inhibiting DNA agarase. Next. An 11-year-old boy presented to emergency with vomiting. Parents gave history of consuming 8 tablets of ferrous sulfate. What is the antidote for iron in this patient? Patient had acute iron poisoning. Acute iron poisoning. This is a very straight question after. For treating acute iron poisoning, we have antidote. The antidote for iron poisoning will be desferrioxamine. Option B is the right answer. So this what we discuss in chapter called chelating agent. At the time I discussed this, I told for treatment of acute iron poisoning, we have some antidote like desferrioxamine, deferriprone, desraxazine. So in your question, they're asking desferrioxamine. Desferrioxamine, one of the antidote for acute iron poisoning. In fact, deferriprone is also useful. For example, a patient developed a thalassemia patient going for repeated blood transfusion, having acute iron overload. For hemocirrhosis, we can use them. And desraxazine, a special iron chelator useful to minimize cardiomyopathy due to doxorubicin. Doxorubicin, an antibiotic anti-cancer drug causing adverse effect of cardiomyopathy because doxorubicin in the presence of iron, they form some free radical. The free radical may cause myocardial damage causing cardiomyopathy. To control that, we need an iron chelator that can be desraxazine. So for treating iron poisoning, the right answer for your question, desferrioxamine. In fact, other options, look here. We have one thing called British anti-illicit, also called dimercaprol. There's a broad spectrum chelating agent useful for lead poisoning, arsenic poisoning, mercury poisoning. In fact, Suxim was also tried for lead poisoning. But one more point, even though British anti-illicit is a broad spectrum antidote, it is contraindicated for treating iron poisoning and cadmium because the British anti-illicit forms a toxic complex when even giving the iron or cadmium. So for treating iron poisoning, cadmium poisoning, BAL is contraindicated. And then for treatment of copper poisoning, we can go for D-penicillamine or trientine or zinc sulfate or potash sulfate. See, the D-penicillamine causing adverse effect of so many things. For example, they cause adverse effect of optic neuropathy, hypersensitive reaction, leukopenia, even aplastic. So today for copper poisoning, the so-called Wilson's disease, for this case, today the preferred chelating will be zinc sulfate. Zinc sulfate is the best answer. So for this question, in your question, for acute iron poisoning, the right answer desferrioxamine. Then a patient present with hyperkalemia, which of the following drug can decreases extracellular potassium level? Option given are atropine, lactic acid, epinephrine, glucagon. This is what confusion. See, in case of hyperkalemia, what we teach in the classroom will be for treating acute hyperkalemia. For rapid control of potassium, the drug of choice will be insulin. That too, IV insulin, that too, regular insulin, along with the dextrose. It's a very good choice. If there is some T-wave abnormality, we can go for one more thing, calcium gluconate. Calcium gluconate. And beta-2 agonist having the property of pushing the plasma potassium into cellular compartment, that way serum potassium level can come down. So beta-2 agonists like salbutamol can be useful for treatment of hyperkalemia. This is what we teach. But the option given here is atropine, lactic acid, epinephrine, glucagon. You should think in the way epinephrine, one of the sympathetic drug having sympathetic stimulatory action, alpha action, beta action. It has a beta-2 agonistic action. Because of this, it can push the extracellular potassium into cellular compartment. Thereby, this drug may decrease the serum potassium level. So, among the given option, you can opt for epinephrine is the right answer for this question. Okay, so normally 3.5 to 5.5 milliequivalent per deciliter will be the normal potassium level. When goes more than 5.5, we say hyperkalemia, mild, moderate, severe. In case of severe hyperkalemia, as an emergency for rapid control of potassium, drug of choice insulin plus glucose. To treat the problem of arrhythmias, TB abnormality, we can go for calcium gluconate. And any case of hyperkalemia, we can supplement beta-2 agonist like salbutamol or terbutaline, albuterol. And bicarbonate also can be tried for correcting the hyperkalemia. Other than this other option, we can remove the potassium by using loop diuretic. Loop diuretic causes hypokalemia. Or also can go for dialysis or sodium polyethylene sulfonate exchange can be done. Okay, so all these are available treatment for hyperkalemia. In fact, you should know these points also. What are the drugs can causes hyperkalemia? Drugs causing hyperkalemia. This is also important. RAS pathway blocker. And then all those two antagonists like spironolactone, eplerenone, drospirenone, and ENaC blocker, the so-called potassium-sparing diuretics, like all those antagonists, ENaC blocker like amiloride, tramtrem. ENaC means epithelial sodium blocker. Here one extra interesting point, trimethoprim, pentamidine, both are antimicrobial. They also having the property of ENaC blocking, epithelial sodium channel blocking property. Thereby, they also causing hyperkalemia. Nefamostat, a protease inhibitor, can cause hyperkalemia. Others causing hyperkalemia are NSAID, cyclosporine, succinylcholine, heparin. They also reported to cause hyperkalemia. So it's called drugs causing hyperkalemia as a treatment for hyperkalemia. Okay, next. A patient was started on anti-tuberculosis treatment. He presented with the tingling, numbness, and other features of peripheral neuropathy. What should be the treatment for this patient? Straight question, doctor. Patient was started on anti-TB therapy, developed peripheral neuropathy. So whenever we say anti-TB drug causing peripheral neuropathy, it could be mostly isoniazid. Isoniazid therapy causes vitamin B6 deficiency, pyridoxine deficiency. So here you should replace with the pyridoxine. So option is between B6. This is a regular teaching, very easy state question. See, isoniazid, one of the first line drug useful for treatment of TB. This drug causing so many adverse effects. For example, one of the common adverse effects causing hepatotoxicity that is due to accumulation of acetylhydrazine. Other problem causing peripheral neuropathy due to B6 deficiency. This is what we teach in regular class. We definitely know isoniazid causing peripheral neuropathy. So, to minimize the problem, we can use prophylactically pyridoxine 10 mg per day. For treatment, we can use pyridoxine 100 mg per day. So here, what is the treatment? It is between B6. That's the right answer for the question. Other than this, isoniazid also causing CNS problem like memory loss, amnesia, psychosis, seizure, rarely causing difficulty in rotating shoulder and hand, called shoulder hand syndrome. It undergo metabolic oscillation, so risk of SLE. It has MAO enzyme inhibitive aortic causing cheese reaction. In this junction, you should know one more point. Isoniazid overdose causes mainly CNS problem like seizure and sometimes coma, altered sensorium, metabolic acidosis. So for isoniazid overdose also, what Goodman given book says, the antidote. The antidote for isoniazid overdose will be administration of intravenous pyridoxine. And to control seizure, we can try with the benzodiazepine like diazepam. And for acidosis, give sodium bicarbonate like that. So anyway, for isoniazid induced peripheral neuropathy, the antidote is administration of pyridoxine. A female presented with galactorrhea. Her urine pregnancy test was negative. MRI had revealed large pituitary tumor. Patient refused to undergo surgery for tumor. Which are the following best drug for treatment of this condition? Very interesting question. Simple question. See, patient is having pituitary tumor and having the problem of galactoria. That means the patient having prolactinoma. Prolactinoma. Patient refusing to undergo surgery. Now, to control the galactoria, what can be done? Before seeing the option, you should come with the answer. This question, to control prolactin, we have to go for dopamine analog. Dopamine analog. Because dopamine going to inhibit prolactin secretion. So dopamine analog. That means we have one thing called bromocriptine. One more drug called cabergoline. Like that, we have two important D2 agonists. With this knowledge, look at the option. The options are leuprolide, bromocriptine, dagarellis, cetylis. Very simple. Option bromocriptine. It's a D2 dopaminergic agonist going to control prolactin release, thereby useful for treatment of galactoria. Leuprolide, so gonadotropin releasing hormone analog, it is not having a role in this case. And dagarellis, cetylis are gonadotropin receptor blocker, and they also don't have a role in this case. Okay, so anyway, for treatment of galactoria, for treatment of hyperprolactinemia, we can go for dopaminergic agonist like bromocriptine or cabergoline. In your question, they give an option bromocriptine, so answer. Whereas comparing to bromocriptine, we have one drug called cabergoline, there is a longer duration action. So what Harrison book says and Goodman says, the best dopaminergic agonist for treating act will be go for cabergoline. That's patient friendly because longer duration action, once a week therapy enough. So that's the best dopaminergic. Anyway, in your question, they give an option bromocriptine. That's the right answer for this question. Next, drug of choice for paracetamol poisoning. This is a very straight question. Okay, paracetamol causes problem of hepatotoxicity. So to control this, we have one specific antidote. The antidote is N-acetylcysteine. So straight question actor. Okay, of course, this is commonly asked question only. See, paracetamol is a simple analgesic antipyretic. Undergo phase 1 reaction by help of CYP2A1. By undergoing phase 1 reaction, it forms one metabolite. That metabolite name is N-acetylbenzoquinoiminoamine. This is the hepatotoxic metabolite. So this is also important question. Which is the metabolite of paracetamol responsible for hepatotoxicity? Answer N-acetylbenzoquinoiminoamine. But yourself, myself, everybody taking paracetamol, but we don't develop liver toxicity because this phase 1 metabolite further undergo phase 2 reaction by glutathione conjugation and become inactivated. That's why we don't develop liver damage with paracetamol. But if the patient take an overdose of paracetamol, say single dose of 10 to 15 gram, then too much of toxic material will accumulated, then it's become very difficult to deactivate. For that, we have antidote. That antidote, this is the question. The antidote is N-acetylcysteine, drug of choice. This can be supplemented with the methionine. So the straight drug of choice for paracetamol N-acetylcysteine. Remember, CYP2A1 is the enzyme causing phase 1 reaction. This can be inducible. This enzyme can be inducible in a chronic alcoholic patient who is on isoniatic acid. So isoniacid and chronic alcoholism will induce CYP2A1. So when you give paracetamol along with the isoniatic acid or along with the chronic alcoholism, the paracetamol rapidly going to form hepatotoxic metabolite. So more chance of hepatotoxicity. This is also extra point. And the hepatotoxic dose is 10 to 15 gram single dose, whereas fatal dose, the fatal dose is 20 to 20 gram at a stage, fatal dose. Anyway, the antidote for paracetamol is N-acetylcysteine. Next, anti-epileptic choice for hypsarrhythmia. Come on, before looking at option, you should know what is hypsarrhythmia. If you know this, and simple. Hypsarrhythmia, it also called infantile spasm. Infantile spasm. Now the answer is simple. Whenever we say infantile spasm, only two main drugs comes to mind. One is called ACTH. One more thing called vigabatrin. Vigabatrin. For a simple infantile spasm, drug I choose ACTH. Whereas infantile spasm with tuberous sclerosis mean drug I choose vigabatrin. So now look at option. Options are phenobarbital, phenytoin, ACTH, carbamazepine. So among the options, straight question, option C, ACTH. That's the answer. Anyway, infantile spasm. That's hips arrhythmia. It's the most common interictal EEG pattern seen with the infantile spasm. So for infantile spasm, the best option will be going for ACTH. Or else, if the infantile spasm with the tuberous sclerosis, go for vigabatrin. Infantile spasm also called West syndrome. Okay. Next, a patient on theophylline therapy for asthma present with the frequent urination. What is the likely mechanism of diuresis caused by theophylline? See, theophylline, a bronchodilator. Theophylline, a bronchodilator having multiple mechanism action. First action, non-selectively inhibiting phosphodiesterase enzyme. Second action, it is adenosine receptor blocking mechanism. So in this, what is the mechanism causing the adverse effect of diuresis? This is a straight question that in our respiratory indicator pharmacology class, we discussed this repeatedly. The answer is adenosine antagonistic action. A1 means adenosine receptor antagonist action. For example, the same thing we discussed. Theophylline adverse effect. And also you should know reason for adverse effect. Nausea, vomiting, headache, gastritis. These are all due to inhibition of PDE4. Whereas theophylline may cause adverse effect of diuresis and seizure. It is because of inhibiting adenosine receptor. By inhibiting adenosine antagonist action. Theophylline may also cause arrhythmia. That is because of PDE3 blocking as well as adenosine receptor antagonist action. So this may contributing to arrhythmia problem. So different adverse effect with a different mechanism action. Next, the term multidrug resistant tuberculosis used when the mycobacterium is resistant to this handle. Very simple LKG question, doctor. So when will you say MDR-TB? If the organism resistant to isoniatic acid and rifampicin, we call this MDR-TB. That's all. So when will you say XMDR-TB? Extensively resistant. When this resistant to isoniatic acid, rifampicin plus one of the injectable second-line drugs like kanamycin, then we can say XMDR-TB. Okay, so here MDR-TB means the organism resistant to isoniatic acid and rifampicin. Straight question. Next, a deep vein thrombosis patient was started on anticoagulant therapy. Next day, the patient presented with the features of diagram shown below, likely drug implicated for this adverse effect. See, patient was given anticoagulant. Following anticoagulant developed some problem in the toes, like a purple color, or can say some ischemic like action. What could be the drug? The answer is warfarin. Why warfarin? See, warfarin anticoagulant acting by inhibiting vitamin K dependent clotting factors. We know factor 2, 7, 9, 10 are vitamin K dependent clotting factor. By inhibiting this factor, warfarin controls DVT, useful for DVT. But the point is, warfarin not only inhibiting 2, 7, 9, 10, is also going to inhibit protein C, protein S. See, the protein C and protein S also vitamin K dependent factors. If these also vitamin K dependent factor mean warfarin inhibiting protein C also. Normally, physiologically, protein C, the normal physiological action of protein C will be inhibition of factor 5 and 8. If protein C physiologically inhibiting factor 5 and 8 mean if I give warfarin, warfarin inhibit protein C also. When you inhibit protein C, this level factor 5 and 8 level will be increases. These are clotting factor causing hypercoagulation. This may cause hypercoagulation causing dermal necrosis, and also in the toes, purple color toes, ischemic toes, they call purple toe syndrome. Solution: warfarin may cause paradoxically hypercoagulation, that is because of inhibition of protein C. So this is a question asking. This and all we discuss in DVT, regular classroom session, all this. Okay, so repeated question, common question only. Because of inhibiting protein C, warfarin elevating factor 5 and 8 level, that causes paradoxically hypercoagulation, dermal necrosis, as well as purple toe syndrome. Which of following is the hypolipidemic drug acting by inhibition of PCSK9? Easy question. See, atorvastatin. Statin mean HMG CoA reductase inhibitor. Ezetimibe. It's a drug inhibiting absorption of cholesterol from intestine. Phenofibrate is a PPAR alpha agonist, thereby activating lipoprotein lipase enzyme, thereby decreasing triglycerides. So all the options ruled out. Only one option is bending. That's called evolocumab. Evolocumab, a monoclonal antibody useful for lowering LDL. This is a drug called PCSK9 blocker. Look here. Actually, whenever we use statin will reduce cholesterol synthesis. When you are decreasing cholesterol synthesis, there will be upregulation of LDL receptor in the liver. This may cause engulfing LDL into liver, thereby statin decreases total cholesterol and LDL cholesterol. Here, what I want to say, the LDL receptor which is seen on the surface of hepatic cells, this LDL receptor may undergo inactivation or undergo degradation by one thing called PCSK9. PCSK9 mean PCSK mean proprotein convertase septilysin hexene 9. So the LDL receptor which is seen on surface of the hepatocytes may undergo degradation by PCSK9. Thereby the LDL level may not be decreased. So to avoid the degradation, I need a PCSK9 blocker that are called alirocumab, evolocumab. So alirocumab, evolocumab are PCSK9 blocker. Thereby I can prevent the degradation of LDL receptor. Thereby all the LDL can be taken into hepatocytes. Thereby circulating LDL level can be lowered. So alirocumab, evolocumab are cholesterol lowering monoclonal antibody and they are useful for lowering LDL cholesterol. That's a question. They given parenterally, injectable, subcutaneous. Now, a opioid patient presenting with the symptoms of respiratory depression, treatment is what? See, it's a case of acute morphine poisoning. See, only in acute morphine poisoning, they have a respiratory depression. So, for treating acute morphine poisoning, we have one specific antidote. What is that? Look at option: naloxone, naltrexone, methadone. One more option, I'm not even recollectible. So the answer is naloxone. Naloxone, intravenous naloxone is the choice. Anyway, remember the point. If a patient having some drug overdose presenting with the pinpoint people hypotension and respiratory depression, but no excess salivation or no excessive sweating, main thing of it's a case of morphine poisoning. So for morphine poisoning, we have some antidote. The antidotes are intravenous given drug naloxone, naltrexone, oral drug naltrexone. Among this, look at the duration action. Naloxone 1 to 2 hours, nalmefene 10 to 12 hours, naltrexone 10 hours. The specific antidote is intravenous naloxone. It is the drug of choice for treatment of acute morphine poisoning. But it's not acting. So to maintain the therapy, we can go for oral naltrexone. So question, acute poisoning treated by intravenous naloxone followed by we can put them on oral naltrexone. Anyway, for treatment of opioid poisoning, answer naloxone. And if the question on de-addiction, if I'm right, okay, suppose the question on de-addiction mean, remember, for de-addiction, the best option will be methadone, or else we can try with the buprenorphine. After that, while stopping morphine, they go for withdrawal symptom. The withdrawal symptom can be treated by beta blocker or lofexarine. Lofexarine is alpha 2 agonist, a new drug. And one more point, to prevent relapse, we have to put them on naltrexone. Naltrexone useful for maintenance therapy for treating poisoning as well as useful to prevent relapse of morphine habit. Anyway, I think your question, acute morphine poisoning, for that the right answer is intravenous naloxone. Now, a patient presented with acute episodes of breathlessness, chest X-ray shows pulmonary edema. History reveals that the patient has uncontrolled hypertension and is not taking the regular medication, which should be the management of this patient. So that means a patient having uncontrolled hypertensive emergency, and having heart failure. In this case, then having pulmonary edema, acute heart failure, presenting with the breathlessness. So remember, whenever it's acute heart failure, the mnemonic 3Ds. One is diuretic, one more thing dilators, one more thing inotropic drugs like digoxin or dopamine or dobutamine. So with this an idea, look at the option. They given intravenous nitroglycerin, intravenous salbutamol, oxygen plus nebulized salbutamol. Look here, patient having acute heart failure, doctor. So here, among your option, dilator they given nitroglycerin. See, it's a vasodilator. Come a very good drug for controlling hypertension also. It's a very good drug for treatment of uncontrolled hypertension, also useful for treatment of heart failure. So among the given option, the best answer will be going for intravenous nitroglycerin. Salbutamol is a beta 2 agonist. This will increases the heart rate. This will worsen cardiac stress. So it's not good for acute heart failure. So question, for treatment of pulmonary edema, acute failure, the therapy will be going for 3Ds, diuretic. For example, intravenous furosemide. So very fantastic drug. This is a drug of choice for rapid symptom relief. Dilators like nitrates can be given, or neseritide, a brain natriuretic peptide analog can be given, or inotrope like dopamine or dobutamine or digoxin can be administered. Anyway, in your question they given dilator nitrates. So severe hypertension with the heart failure, we can definitely go for intravenous nitroglycerin. It is useful for both hypertension as well as for heart failure. Next, a patient presented to hospital after consuming 8 tablets of 0.2 mg of digoxin. His EC shows ST depression and QT changes. What should be the initial management of this patient? See, patient had digoxin overdose. Digoxin overdose. And having the problem of ST depression and QT changes definitely is a serious emergency. For this case, we have to go for antidote. We have one specific antidote for digoxin that's called Digiban, also called digoxin immune Fe fragment. So it is called antidote for digoxin. That should be the choice. After stabilizing patient, we can treat some and give some antiarrhythmic supportively. For example, we say if there's a ventricular tachycardia, we can go for lignocaine. If there is a QT prolongation, we can go for MGSO4. If there is a hypokalemia, we can correct by using KCL like this. So anyway, the choice will be digoxin antibody called Digiban or immune FAB portion of Digiban. Okay. Anyway, remember the digoxin causing so many problems. Extra cardiac. For correcting the X, first of all, whenever you suspect digoxin toxicity, check the serum potassium, magnesium and calcium value, because hypokalemia, hypomagnesemia and hypercalcemia will aggravate digoxin toxicity. So first check this potassium, magnesium, calcium and correct the electrolyte imbalance. And then if there is a atrial tachycardia, treat by using propranolol. If there is a block, give atropine. If there is a bell tachycardia, give either lignocaine or phenytoin. Whereas the best is go for antidote. So in acute digoxin poisoning, we have antidote called Digiban. That's the best option. And remember, for digoxin poisoning, there is no role for dialysis because digoxin having large volume of distribution. If a drug is having large volume of distribution, there is no role for dialysis. Anyway, for your question, the answer Digiban, antidote for digoxin poisoning. Which of the following drugs have least adverse effect on pleura? A good question. They collected so many chapter points and they will give you a question. Option bromocriptine, metformin, nitrofurantoin, methylsergin. Which drug having least adverse effect on pleura? The right answer question, metformin, because they don't affect lung at all. That's answer. Whereas bromocriptine, a D2 agonist, that to ergot D2 agonist. We discussed the same point in Parkinson chapter. We have bromocriptine, cabergoline, pergolide. All these are ergot D2 agonists causing cardiac valve fibrosis and lung fibrosis. So there is impact on pleura. Nitrofurantoin, antimicrobial, useful for treatment of urinary tract infection. This also causes problem of pulmonary reaction, sometimes causing pulmonary fibrosis. Okay. The other problem it can cause peripheral neuritis. In GSP deficiency patient may cause hemolysis, anemia, hepatotoxicity. So remember, nitrofurantoin also having the risk of causing pulmonary toxicity in the form of polyfibrosis and also causing dark brown urine. That's called coffee colored urine. And methylsergin, one of the serotonin antagonist useful for migraine prophylaxis. This may cause adverse effect of severe retroorbital fibrosis and peritoneal fibrosis and also risk of pleural fibrosis. So all these drugs can affect pleura, exhaustion, metformin. So answer for the question, metformin. Next, a TCA toxicity, tricyclic antidepressant toxicity, easy changes with the broad QRS complex and right axis deviation. What is the trait? See, this we discussed in a regular class, TCA poisoning. That is, in a depressed patient, they have tendency to commit suicide. For committing suicide, they may take that drug overdose. TCA are having narrow therapeutic index. They are more dangerous. Now, for treating TCA poisoning, among the given options, what is the best answer? Intravenous sodium bicarbonate, quinidine, physostigmine, lignocaine. Look here. Actually, for TCA poisoning, the first choice should be the patient may have metabolic acidosis. So, correction of acidosis by using bicarbonate. That's the first choice. So, answer for the question, intravenous sodium bicarbonate. Now, look here. What Harrison book says and what Goodman-Gilman says. Look here. TCA poisoning patient will have symptoms of 3Cs. Remember, 3Cs mnemonic. The 3Cs are cardiotoxicity in the form of arrhythmias, convulsion, and altered mental status like comatose status. Sometimes they go metabolic acidosis. So, the first treatment should be correction of acidosis by injecting bicarbonate. That's the first choice. Other therapy can be symptomatic. For example, if the arrhythmia, use some anti-arrhythmic like lignocaine, betalium. But once again, avoid using class 1A drug because class 1A drug having anticholinergic action. TCA also having anticholinergic action. So, for treating arrhythmia due to TCA poisoning, don't use class 1A drug. That's very important. And for treating convulsion, we can try diazepam. And for coma, only supportive therapy, airway, breathing, circulation maintenance. And acidosis, I told first choice will be, first line drug choice will be administration bicarbonate. Once again, in TCA poisoning, there is no role for dialysis because TCA having large volume of distribution. This is also important. Next, the most effective drug to control tremor, rigidity, and bradykinesia in patient with the Parkinsonism. Options are selegiline, entacapone, levodopa, haloperidol. See, somebody says option like donepezil and thiridazone and then selegiline and then haloperidol. Some people are reading questions, they're putting in DAMS exclusive club, they're putting this. Somebody putting this option. I don't know what was the option. I don't know. But anyway, if you go for this, selegiline, entacapone, levodopa, these are all drugs useful for treatment of Parkinson's disease. Whereas haloperidol is a D2 blocker, it is never used. In fact, it's going to cause Parkinsonism. So this is ruled out. Ruled out. Now, among these three options, the most potent dopaminergic drug to control hypokinesia, rigidity, and tremor is levodopa. That's the best answer. Okay. Selegiline is a MAO-B inhibitor. Entacapone, catechol, or methyl trans blocker. This is also useful. They are adjuvant therapy. The main choice is levodopa. Suppose if they given this option in a question, donepezil, it's a cholinergic drug useful for Alzheimer, ruled out. Thiridazone, again antipsychotic, D2 blocker, ruled out. Haloperidol, D2 blocker, ruled out. So only one option, selegiline, that can be useful for Parkinsonism. So exactly what was the option, we don't know. Anyway, among the option, best is levodopa. Anyway, selegiline, remember, MAO-B blocker, entacapone, COMT blocker, levodopa is the D precursor of dopamine. The most potent dopamine drug is levodopa given with the carbidopa in ratio of 4:1. Here, carbidopa is a peripheral dopa D carboxylase inhibitor. Thereby, large amount of levodopa goes to brain and having less amount of peripheral toxicity. That's advantage. Anyway, depending upon question option, you can vote for. One more peripheral dopa D carboxylase blocker name is benzalazine. A patient presented with a severe headache with photophobia and phonophobia. Which of the following drug can be provide immediate relief for this patient? See, before going to option, look at the history. Patient presents severe headache. and having photophobia and phonophobia. When they see light, headache aggravated. When they hearing sound, head aggravated. It's a typical history of acute migraine problem. Now, for treating the acute migraine, we go for vasoconstrictor. Vasoconstrictor. When you say vasoconstrictor, one group of drug is called ergot, one more group is called 5-HT1B agonist, like triptans, smart triptans or triptans. So with this in mind, look at option. Propranolol, smart triptan, topiramate, fluorescein. Very simple. Smart triptan, a 5-HT1BD agonist. It's a vasoconstrictor. That's a wonderful choice for this question. Whereas propranolol, topiramate, fluorescein, all are useful for prophylaxis migraine, not for treatment of acute migraine. Okay. So anyway, for this question dealing with the acute migraine. For acute migraine, the best is going for vasoconstrictor. Two classes of vasoconstrictor there. One group is called ergot, one more group is called 5-HT1B agonist. They call triptans. The example for ergots are ergotamine and dihydroergotamine. And be careful while using vasoconstrictors in patients with the hypertension or ischemic disease. Triptans, lot of triptans are say the common triptan, smart triptans, risatriptan, almotriptan, like that. But the ergots causing severe vasoconstriction, they may cause gangrene of the foot. It is called Saint Anthony fire. So one of the adverse effect ergots, they causing Saint Anthony fire called peripheral gangrene. And ergot causing uterine contraction abortion. So ergots are unsafe in pregnancy. All these are old question. Anyway, remember the point. And in your question, they got smart triptan. That is the right choice. Whereas for controlling the recurrence of migraine, we have some prophylactic drug. So propranolol, nadolol, or non-selective beta blocker. They are the commonly used drug for prophylaxis. And they give fluorescein option. Fluorescein, one more drug, Parastomal, both are calcium blocker. In fact, fluorescein primarily a calcium blocker, also having sodium blocking property and antioxidant activity. And they got topiramate, valproate, gabapentin, all are anti-epileptic, useful for migraine prophylaxis. The other drug useful for prophylaxis are amitriptyline, one of the TCA, clonidine, alpha antagonist, botulinum toxin, and then 5-HT2 blocker like pisotafan, cyproheptadine, methylsergin. Cyproheptadine, a first generation antihistamine, also having anti-muscarinic action and serotonin blocking action. It is useful for prophylaxis of migraine, also useful as an appetizer, useful to control symptoms of serotonin syndrome, carcinoid syndrome, and also useful for treatment of patient with delayed orgasm. Of course, methylsergin, a drug useful for prophylaxis, causes adverse effect of retroperitoneal fibrosis, retroorbital fibrosis, pleural fibrosis, so it's not in use. So in this question, right answer, smart triptan. Next, drug useful for ventricular tachycardia. Options are IV amiodarone, oral amiodarone, IV beta blocker, oral beta blocker. See, this is a tricky question. When they asking, I think they give some image also, I think so. For ventricular tachycardia, currently the best option drug therapy mean intravenous amiodarone. Okay, so according to advanced cardiac life support guideline, the first line drug of choice for treating VT or VF will be IV amiodarone. It's a first line drug of choice. Other thing, we can try lignocaine, even mexiletine, like that. The first choice will be your amiodarone. So look at ventricular tachycardia, one of the dangerous medical emergency. Sometimes they have ventricular fibrillation. So for this case, what the best thing is, look here. Best thing is maintaining airway, breathing, circulation, and also doing CPR, and also doing DC shock, DC conversion, giving shock therapy. That's a treatment of choice. Whereas when they're asking drug of choice mean, we go for drug of choice mean IV amiodarone is the best choice. Or else we can go for lignocaine. So what ACLS, Advanced Cardiac Life Support Guidelines says, IV amiodarone is the first line drug of choice for treatment of VT or VF, the causing cardiac arrest. So for your question, go for IV amiodarone. Next, mechanism of botulinum toxin. Very simple question. Botulinum toxin, in the class we say repeatedly B mnemonic, B for blocking the release of acetylcholine. That is option A, inhibiting release of acetylcholine. That's the right answer. Okay. Other option, no need to search because only single response question. Botulinum mnemonic, first B for blocking. So on regular class we discuss inhibiting vesicular uptake. It is by Vesamycol inhibiting vesicular uptake ACH. Inhibiting uptake choline, that is hemicolinium inhibiting uptake. Inhibiting NM receptor seen on neurovascular junction. This is blocked by non-depolarizing skeletal relaxant like atracorium, pancronium, vecronium, rocronium. Anyway, this is what we discuss in a regular class regarding synthesis, storage, release, and metabolism of acetylcholine. Look here. The choline uptake is the rate limiting step in the synthesis of acetylcholine. This can be blocked by hemicolinium. So choline uptake blocked by hemicolinium. Whereas acetylcholine taken up by vesicle, it is called vesicular uptake of ACH. It is blocked by Vesamycol. So the vesicular uptake of is called vesicle. Vesicular uptake of ACH blocked by Vesamycol. Whereas the release of acetylcholine can be modified by two things. One is called botulinum toxin, one more thing is spidervenom. Here botulinum, mnemonic B for blocking the release. This is what your MC question. Spidervenom, mnemonic S means stimulating the release of acetylcholine. Okay. Of course, the calcium, pre-symptomatically we have calcium channel. Through the calcium channel, calcium will enter. The calcium will promoting release of ACH. If there's a defect in the calcium channel, there may not be proper release ACH. This may cause muscle weakness. It is called Lambert-Eaton syndrome. Okay. And acetylcholine acting on muscarinic nicotinic receptor. Muscarinic can be blocked by anti-muscarinic like atropine. Nicotinic having NM and NN. NM blocked by skeletal muscle relaxants. NN by ganglionic blocker like hexamethonium, trimethophan. Anyway, in your question, botulinum toxin mechanism action acting by inhibiting release of acetylcholine. Okay, I think all the important question, whatever I recalled, I discussed. If any other question left out, can you just post me? I will read to answer all your questions. So I think this NEETPG 2022 was very, very easy. I think all may be done very well. Yes, may God bless you. Thank you. All the very best.